Hello, am I audible?
Yes, ma'am.
Yeah, so can we start with this?
Wait, ma'am. 1 second.
Okay. Yeah, please let me know when.
Okay, ma'am. Ready.
Yeah, okay. So, good evening to all present here. So, today we are going to see bouncers and sitters. Okay. So, something like, previous year question papers from where there are bouncers. That is, something which is difficult to crack and something which are easy. Still, we just think that this is the answer and apparently choose the wrong ones. So prosto being something very difficult, I myself, was somebody who thought would not choose prosto as my department, but I'm very grateful that I ended up choosing it. So I'll make it easier for you. Today we'll think of some certain 30 questions which we can discuss today. And with that, mostly case-based questions which will help you to answer faster, better, and most importantly, to not choose the wrong ones. So we'll start with our first question. So the first question which we'll see have come in the NEET exam. Why are the maxillary teeth arranged buccal to the crest of the ridge? Now what we have are four options, okay? On that, here we see that option A is to place them in neutral zone. Option B to provide space for the tongue to move. Option C to form buccal corridor. Option D to avoid forces directly acting on the crest of the ridge. Now, what you should take care is to avoid the definitely wrong ones. Here we can see that the first, leave the first one, we'll see from the C to form the buccal corridor. Now, what is buccal corridor? Those are the spaces that are formed when a patient talks on the angle of the lip, on the angle of the mouth. So for that, if we set our teeth little more buccally, when a patient smiles, you see that there is two closed, black holes which present here, right? When we place it too much buccally, the buccal corridor won't be formed. So definitely not, that is not an option. And option B, you can see that it provides space for the tongue to move. Now, when we see tongue is something which mostly affects the mandibular denture. Now, when a patient talks or when you talk, you can see that the tip of the tongue is mainly affecting on the lingual surface of the upper anteriors, not on the posteriors. So definitely option B and C we can eliminate. Now, for a UG student to understand a neutral zone is difficult. I'll teach you with a example. Now, for all the Malayali students, they would be very familiar with this movie Punjabi House, where you see this scene, a very hilarious scene, and here you can see that the denture, that is, the actor is being supported from two sides, that is the cheek and the tongue. Now, what is the idea behind it is when we give a patient a denture, He or she should be very comfortable with it, that when she, uses the tongue or the cheek or the muscles should not affect it. So dividing the word neutral zone, it's a zone where the forces acting are, equalized, neutral. So that is the zone where we set the teeth. Now, when we are setting the teeth buccal to the crest of the ridge, it is to protect itself from the neutral zone. So now I think that whenever you have an idea or a question comes about neutral zone, it would be easy for you to crack because you remember what is written here. And also remember the image that I showed you. Neutral zone is like one of an important, a tricky thing to understand. But once you understand, it's easier to, use it on your questions. Next, moving on, which is the following is a pre-extraction record not useful for measuring a vertical dimension. Now, always remember to not overlook each and every word on your question. Now, they have told not useful for measuring vertical dimension. Vertical dimension means the height of the face. Okay. Now to measure that, there have been several things. Now to use a common sense here, you can see that they have told facial profile photograph. Yes. Now facial profile photographs shows the height of the face. Cast with intact teeth definitely have 2 points. That is upper and a lower point. Vertical height measurements, that is facial measurements, which have been there for a long time now, that is also helpful. Now see this image. These are the things that can help us to determine the vertical dimension. When we check a vertical dimension, we should know that there should be 2 points, one in the maxilla and one in the mandible. Now on the option, when they say tooth shape and size, definitely with a little bit of, presence of mind, you can say that definitely this is not an option. Tooth shape and size are used for determining in the next step. That is tooth selection during trying to determine the shape of the tooth, to determine the size of the tooth. It doesn't play any role on determining the vertical dimension. That way, we can know that option A is not useful. Whenever I'm discussing these questions, I'm discussing that certain questions, which can come in a twisted ways also. That's why I'm mentioning and explaining why not to choose certain options. Moving on to the third question. One of the ways to alter anterior guidance. Anterior guidance and condylar guidance is something that, kids break their heads off because, they don't understand what is this guidance. To simplify, I'll simply teach you with an image, okay? What is anterior guidance is first to move your teeth. Now, imagine this is your lower anterior, this is your upper anterior. The movement of the teeth for function. Now, when we move the teeth like this, there is that shift that is happening, right? That function is what we call anterior guidance. Now, check this image. What all do you see? You yourself try, changing your teeth or shifting your teeth. You see that there is a movement. And what are the things that are severely being there? The lingual concavity of your upper tooth, the incisal edges of your lower tooth. Yeah, right? And obviously, it comes to the incisal edges of the anterior teeth also. When you see, you slightly move it. When of angle is formed with this is what is anterior guidance. Second, condylar guidance. Now, in this option, the option C they have given us condylar guidance. Kids, please understand that condylar guidance is God given. We can't alter the condylar guidance. Only thing we can play with is an anterior guidance. Now, with the image, you can see that alter the lingual surface of the upper anterior. Yeah, we can alter it for a good anterior guidance. Altering the incisal surface of an upper anterior, which is like, the last thing that we can think of, by altering the lingual surface of lower anterior. Now you see where is lower anterior's lingual surface coming into action? It's definitely not. So with that, we can understand that option A to alter the lingual surface of upper anterior can act and help us, in altering the anterior guidance. I hope you guys are clear. Next, I have chosen a question which is overdentures. There is CD, then there is OD. Overdenture, that is in the question itself, they have told tooth supported overdenture. If there is a tooth, Definitely there is caries. Definitely the prophylaxis should be good. It should be healthy. Now, tooth-supported overdenture attachments are indicated in all except. So they have told to tell, okay, what are the contraindication? Is in the options, is there a contraindication? Choose that is what they have told. To, confuse our mind, they have been like all except. So now let's slowly see what are the options. Option A is xerostomia. Option B, reduced interarch distance. Option C, loss of maxilla or partial mandible. Option D, A and B. Now, when there is teeth, and if the patient has xerostomia, you can see that, the rate of oral prophylaxis can be less. The rate of, caries can be more. That way, tooth-supported overdenture cannot be given without correcting xerostomia. Second, reduced interarch distance. Now, reduced interarch distance or interarch space means a patient will have certain space between the arches. Now, if we have at least 10 to 14 of space, is when we can give an attachment. Simply understand that. While directly giving a complete denture only, the acrylic thickness comes. With that, we are giving an attachment. Obviously, if the space is reduced like this, then we can't provide an attachment. Therefore, we can see that reduced interarch space or a distance is a contraindication. C is loss of maxilla and partial mandible. Attachments are provided even in cases where the maxilla have been in a congenital deficiency and all, overdentures are given. So with that, we are confused. Like, is it A or B? Is it A or B? So we see that B, they have given that option A and B. So option A and B is correct. And these are the indications and contraindications. Now, below are the images that I have provided for an overdenture. You can see that they have several attachments for which we need severe increased distance. So this indications and contraindications you can just read with what the idea I have given, so that you can easily understand that where it is not given. That way we go with option D. Now again, coming into an anterior guidance question, patient with more upright central incisors than usual. Now I am sitting little more bented. So the central incisors are more upright. Okay. They are not little tilted, or they are showing that it is like straight, like a parade. Now, if they are upright central incisors than usual, the finding possible in this case is they have told canine guidance can be difficult to establish. I'll tell you what is canine guidance. Posterior crossbite can happen, which is definitely a rare condition. Labiolingual more positive inclinations. That is again, the chances are less, and posterior open bite. That is not something that comes with a anterior guidance. Here, what they are trying to tell you is the question correctly tells you that it is more upright than usual. When you see that here I have given, it's straight like a parade. When they are more upright than usual, it's like this. When they move it, you see that the canines are something which don't touch, move like this. So then when the canine is moved to the left or the right, it is difficult to be established because already it is very upright. So it has to come like this. This way, the space for the canines are increased. So it is difficult to establish for a doctor what is the canine guidance. To understand that is difficult. And that way, option A is the answer. Now we have discussed two questions on the guidance part. I've told you what an anterior guidance is, how to easily understand which parts affect the anterior guidance. I've also told you about canine guidance. Now again moving with CD, sounds affected due to faulty placement of incisors during teeth setting. We have several sounds, not only labiodental, lingodental, bilabial, lingoalveolar, you have several sounds. And these words can be difficult for you to remember. Like, okay, labiodental. I'll make it very easy for you. Always on the anterior teeth, you see this image that I have marked 1 to 10, and I have showed you, the arrow marks with 1, 2. When we say bilabial, it is two lips touching. Similar way, you can just memorize this image of, with the word play, labiodental, labium, lip and a dental. Lingoalveolar, posteriors of a lingo means back of a teeth. Letroplex, palatal, where the palate comes into action. Pharyngeal, laryngeal, there are place of articulation and we can determine with that. That image when you see, you can actually understand. And here, labiodental is something which comes in the anterior. That is lip and faulty placement of teeth they have mentioned. So obviously there is dental and therefore, the sound here, there are two things, lingodental and labiodental. You should understand that when the teeth are faulty placed, the answer is going to be labiodental. The front sounds are what is going to be affected. The similar questions I have added in the next, coming questions so that it will be easy for you to, repeat. Repeating is something that you should start doing. Like when I tell you this 30 questions, this is under certain questions that I have repeated in certain ways so that, you come across and revise it again and again. Then after a long time, it will be in your mind. Okay, neutral zone means this, anterior guidance means this. These are the terms which we use for vertical dimension like that. Now, moving on with our seventh question, which of the following act as a local factor for a denture stomatitis? Candida associated denture stomatitis. Now, denture stomatitis or candida lesions have systemic factors and local factors. Systemic means which also affects, medical terms are more in that. And there is also local factors that is more in patient's hand. So here we have options like diabetes mellitus definitely related with candidiasis. Nutritional deficiency, yes. Steroids, corticosteroids are like, enemy. And then there is denser uncleanliness. Now you're thinking, okay, fine. All these options are already what is affecting. Now, what is the answer? They have not even given all of the above. Please understand, this is where you should read the question again. They have asked a local factor. Local factors, denture and cleanliness. Now here is the box I have provided you for, systemic factors and local factors. This, kids, you have to repeat in your mind so that, suddenly when certain things comes, you understand that, okay, this is the local factor. Here, dentures means in dentures, what all comes? The denture cleanliness, the health of the denture is affected. So that is a local factor. So again, the answer is denser and cleanliness. Moving on, what is the appropriate time to fabricate a custom tray before taking a final impression? All my kids would be in prosto posting, making custom tray and all that. A very tedious job. I know it takes time for you to handle that. But have you ever thought which is the correct time to fabricate it? You know what is polymerization shrinkage, right? From the time we have added the monomer and polymer, it's like I'll show you the settings. It's like a paper. The paper when it is flat and when it is shrunk, you see that there is a difference in the area. That is simply what is polymerization shrinkage. Now, while doing it, initial 30 minutes, there is polymerization shrinkage, and up to 9 hours, this can go on, after which it becomes stable. Now you have a patient which you have to do, early, you forgot to make a tray. It's fine. You should put the custom tray with the cast into hot water for 5 minutes and therefore it, hastens the polymerization. If you're doing, there is another one technique. The custom trays can be made, they have plates like this which are moldable, the acrylic. So it is light cure. If you're doing a light cure, the whole polymerization takes place at the same time. So not need to do. But here they are asking the polymerization time after preparing a custom tray. Remember, you should always have this in mind that it's 9 hours before. 9 hours before means we have 8 hours for sleeping. So before that, 9 hours before the custom tray should be made to take a final impression. Moving on again with an impression question. That is secondary impression. Now, for primary impression, impression compound is used. We know that when a patient comes, we try several stock trays. Nothing is something that is correct for the patient because the stock trays are something which is made with a selected measurements. Our patients don't come with the same; they are customized. That's why we make custom tray. Each patient have different, measurements. So the custom tray to make that we need a primary impression. Now this primary impression by impression compound is one of a good material. Definitely there are other materials that we use. They are mucocompressive, cost effective, more stable, thermosetting. They're not thermosetting, they're thermoplastic material. Thermosetting means, to chemical reaction they just set. After that, we can't change them. They're thermoplastic. When you heat it, it becomes soft. When you cool it, it becomes hard. And we need it to be a compressed impression so that we get all the areas around the arch, that is around the mandible and maxilla. We need every area because of which we need it compressed. So thermosetting material is definitely out of our scene. They are more so. This is how we mold a impression compound, right? Before taking a secondary impression. So the answer would be mucocompressive. We have more stable options available right now. It is cost-effective options available, but the mucocompression of impression compounds are much important. Moving on again with the vertical dimension questions. This is what I told. Repeat the same things again and again. So that it will become, it will be etched in your mind. A complete denture patient is experiencing chattering sound while talking. Chattering sound while talking. What could be the cause? A new denture provided to a patient, and he or she have a chattering sound. That is mostly that the teeth are hitting together and making kada kada kada. You know that sound, right? It is making certain sound. Now, the options is patient is having neuromuscular problem. Definitely not related to sound. Patient must practice how to talk with the denture. When we provide a denture to a patient, obviously there is slurring of space that can happen, and also there can be difficulties to measure or talk. Sorry, the difficulties to talk certain words, but there won't be that will take time. But the chattering sound won't come. Chattering sound occurs when there is increased vertical dimension. What is vertical dimension? A patient, if we provide patient with a certain vertical dimension, if it is extended, like the patient have very stretched face, the denture's teeth will keep on hitting when the patient is talking. So here, remember that there are two options when it comes. Either we have given a porcelain teeth, which we give very, rarely, or they are too close to touch each other. When they are too close, when we raise the VD and we provide it, and what it causes, on a long term, the patient will come back to you with TMJ issues, speech issues will be there, and mastication problem. Patient won't be able to bite, right? Because we have given it so close to each other and so stretched that patient won't be able to bite. So obviously in this they have given a chattering sound. So the option is increased vertical dimension. You see this image, the patient looks very, tired. He feels tired after trying to use that denture which we provided with increased vertical dimension. Sorry that the earphones keep on falling. Next, moving on with our 12th question. A 70-year-old patient of denture wearer for 10 years is finding his floor above the level of bone crest and ulcers on the lingual surface. The reason could be patient is 70-year-old. That is, a debilitating patient. He have been wearing a denture for 10 years. What now can be a sudden issue that has come after 10 years? Definitely, if there is increased video, the patient would have come back to the person, not, he wouldn't have stayed with 10 years with that. Second is bone resorption. Now, here you see that he's, he's finding his floor above the level of bony crest. Mandible's crest is here, and above that level, I show you that the floor of the mouth is seen. Now here you can see that when the floor of the mouth comes above it, when there is severe resorption. We have bone resorption also. But again, in the question, there is another one point that ulcers on the lingual surface are seen now. Ulcers on the lingual surfaces are really seen when you hit on the certain spots or landmarks of the mandible. So here in our option, we have bone resorption is option B. Option C, we have bone resorption and prominent genial tubercle. Option D is frenum is not relieved. If the frenum is not relieved, definitely there will be pain on the lingual surface if the lingual frenum is not relieved, correct? But again, the bone resorption option is not there. So definitely when you hit the genial tubercle, there would be severe problem. When the bone resorbs, the genial tubercle will come in a level with the resorption and the dentures will keep on hitting there, causing pain to the patient. So the option is option C. Again, going with the case based. Why I am taking more case based is when you see the question is being too large, you feel that the question is being too tough. But please understand when there are more information, it's easy for us to rule out the wrong ones. Here again, a 70-year-old male, non-smoker. The patient is not a smoker with diabetes and being edentulous from 6 months came for rehabilitation. Yes, the question is clear. On oral examination, there were white patches on the alveolar mucosa. Suddenly, we'll go to our oral medicine and radiology. Oh my God, is it a premalignant lesion? And the patient is unaware about it. What is the treatment. Wait and watch. When a patient comes for rehabilitation, we can't just wait and watch. Second one is local application of triamcinolone. Now, applying a steroid there cannot be an option before rolling it out. Here on the question, it is clearly given that the patient is a non-smoker. So immediate biopsy can be ruled out. When the patient is a smoker, definitely a premalignant lesion can become. So the option B is proceed with denture construction to maintain the nutrition and then call for review. The chances for the white patches that can come is due to keratosis. You know, the constant movement and all that can cause a white appearance on the mucosas. When the patient is non-smoker, you can definitely rule out the pre-malignant issues because mainly smoking has been an issue. So that way we go with option D. Again, which of the following is correct support area for edentulous arch? 1 second. Yeah. Here again, kids, please try to remember three numbers. I know you have been remembering and it's taxing for you, but still for maxilla mandible, there is a typical number for which is the correct support area available. If you don't, it's easy. It's 22 and 12. You know, 10 ka difference. So 22.96 in this options, you can see that it's 22 for a maxilla, 12 for a mandible. Again, another one is 45 centimeters square. That is the periodontal space for a dentulous arch to be a supporting. Here, so leave option C. You see A, B, and D. You see 22 is correct there for maxilla. Rest for mandible, they have put 15. For maxilla, they have put 19. We can roll that also out. So here, remember this 22, 12, and 45. So 22 is there in the option. Therefore, option A is the right answer. I'm including certain numbers that you have to remember so that it will be easy for you. Now moving on with our half. We have come to the half. I hope you're understanding what I'm telling you. If you want me, please ask me so that I can repeat to you again. If you don't understand anything that I am talking about. Now going with the 15th question. During eccentric extensive movement, selective grinding is done in which of the following order? Selective grinding is again like guidance. We break our head not knowing what is protrusive, what is balancing, what is centric. Centric means the certain occlusion of the patient. Protrusive means when we make the mandible forward. So lateral means lateral movements. Now here I'll give you an easy mnemonic to understand and remember, which is the order in which we do. B, W, P. We first take the balancing, then we do the working, then we do the protrusive. That is the order in which we do. Remember, best wishes prosto. Balancing, working, and protrusive. That is the order in which an equilibration procedure is done. Why an equilibration procedure is done? So that the contact is not an interference. When a patient moves the denture in all sides, right? They don't have a root to support the teeth to not move it. It's all in a plate. So therefore the movements are moved. So it's as a doctor or as a prosthodontist or as a general dentist, it's our responsibility to remove all the interferences. And how can that be done? On a balancing means the movement. When you move a mandible to one side, the side which is functioning is working side. The side which comes along with it is balancing side. Then there would be protrusive that is moving forward. So best wishes, prosto, balancing, working, protrusive is an order. So the answer is option C. What should be the premolar position during teeth setting? Our first question was again positioning of the maxillary teeth, posterior position buccal to the ridge. What is the reason? Now always what should be the position of premolar? It is buccal to the ridge, lingual to the ridge, depending on bone resorption on the crest. We are not giving a viva to tell, depending on bone resorption. That is not an answer. It's a vague, very vague option that is given. Again, check this. After setting the anteriors, from the canine's incisal edge or the canine's buccal, we draw a line through the retromolar pad and which cuts the occlusal rim from the middle, and that is where we set the teeth. This is from the retromolar pad's middle to the canine. When we draw it, it automatically comes on the crest of the ridge. The premolars are set on the crest of the ridge. What is the correct method for impression removal in a patient? Now, impression taking itself is a task which we learn by taking repeated impression. Your first impression would not be same as your 10th impression. So that is something that comes by hand. There are certain you see that the hand should get better. So here, what is the correct method? You cannot slowly tease it out. When you're slowly removing it, you're again affecting the impression. Impressions are not very hard like a metal, right? It can deform. So that way, here it is slowly teasing out is not an option. Rapid with a jerk, rapid with a horizontal direction, and slow gradual force. Slow is not there in removal of impression. Rapid with a jerk is always a easy way to remove an impression. You just jerk it. Normally, what we do is we put the doctor puts the fingers inside, give a jerking motion, and then rapidly remove the impression. So rapid with a jerk, so that you are not compromising the clarity or the quality of your impression. Moving on with our 18th question. Reason for improper impression which occurred due to setting of alginate. When we give alginate for an edentulous person, you see that alginate is a very beautiful impression material, but it comes along with its own issues. Now here they have asked what is the reason for an improper impression which occurred due to setting of alginate before insertion into the mouth. Early loading of material is an option. Addition of less powder to water makes the impression, right? Very tacky. Mixing at room temperature. Temperature is a word that you should always correlate with alginate. Using hot water for mixing. Now, here, what you should understand is temperature is directly proportional to setting of alginate. I mean, directly connected to the setting of alginate. Increase the temperature, you decrease the setting time. So, when you have to do an alginate mixing, always you should see that it is controlled around 20 degrees. And here we see that the temperature can be an issue. So obviously using hot water means increase the temperature. That means shorter the setting time. So using hot water for mixing is the answer. Again, coming to a large question, remember when you have a longer question, it is easier to answer. A patient came to dental clinic with his upper denture, which he used to wear for last 10 years, his lower for 3 years. Okay. Previously, his lower premolar was present. He was happy with his dentures, but now he has stopped wearing because of loosening of denture. When you examine, you notice flabby tissue in his anterior region. What will you do now? What is a flabby tissue? A movable thick tissue is what we call a flabby tissue. They have mentioned that in before the premolars were present, now the premolars are not present. When the posteriors are not present, patient obviously brings his lower mandible forward to have chewing capacity. That means severe force is given on the anterior region. That's why they noticed a flabby tissue. Now, immediately when you see a flabby tissue, what shall be done is the question. Option A, urgent surgery. Option B, make a new denture. Make a new denture means you're again providing a denture. You're not caring about the flabby tissue. Take a window impression where the tissue will get space through window. Strong compressive primary impression than secondary impression. Now, for a flabby tissue, giving a compressive impression won't affect. Just like, remember this hands, when we press it, it's pressed. When you remove, it comes back. That is the same effect of a flabby tissue. Now, giving an urgent surgery is not an answer. First, we should always remember as a clinician, can it be solved without a surgery? Can the patient be, treated with a very minimal treatment? If yes, go with that. That is the biggest answer for flabby tissue is window technique. I'll show you a window technique. This is the window technique. You see the flabby tissue, right? Just, when you take and press your instruments towards, it just compresses and comes back. This is the window technique where you cut that region so that it is relieved and then take an impression without affecting, without compressing it. So what is the answer? Take a window impression. Whenever the question has flabby ridge, search for window impression. Next, irregular positioning of maxillary anterior tooth. Lingually results in which abnormal sound? Again, as I told you, I discussed this earlier. It's again labiodental. Also remember that lingoalveolar can also have the same problem, but we don't have thankfully that option here to confuse us. So it is labiodental. Okay. Moving on with our last set of 10 questions. So, a patient came to the OPD with upper and lower denture having complaint of whistling voice while talking with his denture. What can be the cause of whistling through the denture? Now, whistling is mainly due to setting of the teeth. The setting of incisors have not been right. Again, when there is vertical dimension issues, again, the whistlings can happen. And also, stable or unstable cases, the base is not stable or unstable, is definitely not a part of a talking or whistling sound. They have definitely measured that there is a whistling. So remember, when whistling comes, again, anterior teeth setting have some issue. Again, vertical dimension have issues. When the vertical dimension is checked, it's with F and V. When, you set it more upwards, the F will start sounding like V. When you place it more downwards, the V will start sounding like S. So here we see that option 1 and 5 are correct. Artificial chair side reliners are avoided. Relining is something we do when you don't have any other option. Relinings are like immediate help for prosthodontists. Something that we do when you don't have a time or an option. The patient needs immediate results. That's when relining is done. Now, when it is avoided, Obviously, relining is again done with a polyethyl methacrylate, which is again, it can cause chemical burn. And then porosity and poor color stability. You can never match to the particular denture that you have given because artificial reliners comes with their own shade. You can't match with that, and porosities can happen. Chances of error while positioning the process. There are two types of relining: laboratory relining and chairside relining. Now, if you are going on with a chairside relining, obviously the positioning of the processes can be affected. Now, we see that all these options are certainly right. Therefore, we go with all of the above. Now, moving on with our next question, the 23rd question. After getting a new denture, patient complains of tiredness while wearing it. I'm very, very sure that you guys would be knowing the answer with the tiredness only because there would be one image that we discussed earlier and he got relieved of tiredness after removing the denture. Please tell me that you know the answer because yes, it is option A. PPS is never mentioned with tiredness. If there is extended PPS, the patient will have other problems with swallowing and all. Decreased vertical dimension of occlusion, the patient will have angular cheilitis, CMJ problem, inadequate centric relation, there would be occlusal disturbances. And here you know that the patient is tired. Remember when the muscles are stretched, that is increased video, the muscles are stretched. I showed you an image like a patient sitting with this side. Yeah. So the answer is increased video. Now, palatal tori is removed when? What is a tori? Tori means a bulge or a strong bony protuberances seen in both maxilla and mandible. In maxilla, the position and the determination of the bulge of it, we sometimes we can relieve it, but if it is impinging to the soft palate, you are definitely affecting the seal of the denture. Again, it is preventing, yeah, that is what posterior palatal seal, and it does not provide undercut. Like certain tori will have an undercut, to which it has increased retention in mandible. Then there is cancerophobia. The patients are scared whether this protuberance is a cancer. In these cases, we see that all of the above is an answer, which this was the options written, and you had the option of all of the above, A, B, like that. Remember, everything is an answer. This is the image of a tori, which you know casually tells that all these options, which envisages the soft palate, it is preventing you to take a PPS, this does not have an undercut, and this when you look, the patient thinks it's a cancer. So in these cases, this palatal tori is removed. Palatal tori is not removed if the sizes are smaller. It can be used as an undercut. It does not impinge to a PPS. It can definitely be placed there by just relieving it on a ledge. Moving on, ideal requirement of a denture fabrication on a debilitated patient. That means the patient is very old, the patient have certain systemic diseases. Now, what a dentist should take care when he or she is providing a denture is the question. There should be more coverage. Why? Because there have been severe resorption. Now, when there is resorption, if you don't have a proper coverage, it can affect. Broad occlusion. Why broad occlusion? Because there is severe thinning of the bone. When you give broad occlusion, the patient may be able to bite more. Porcelain teeth, good peripheral seal. Yes, good peripheral seal is there. Porcelain teeth we don't generally give because when we provide a patient with a porcelain teeth, it is more stronger teeth. The patient will have to provide more effect or more biting force for the patient to feel that he is being chewing. Then non-pressure technique. Obviously, by giving severe pressure again on the denser basis, what happens? Again, the resorption increases. So here, what is the again? I have provided the reasons that can also happen on the debilitated patients. If there is looseness, it can be provided due to proper seal lack, inadequate occlusion, poor adaptation. So Please remember this, what affects a debilitating patient. So again, porcelain teeth is out. Porcelain teeth is out because you never give a porcelain teeth to a debilitated patient. It actually does more disadvantage than an advantage. So ruling out three, we have 1, 2, 4, and 5 as an answer, the ideal requirements. What happens when premature contacts are not corrected after 24 hours of denture delivery? Delivering patient with a denture is not only, we delivered the patient goes bye, tata, bye bye. That is not the situation here. The review is where, that talks the dentist good thing. How can we correct the patient being able to adjust to that? Now, after 24 hours also, the premature contacts means the contacts that the patient feels when, before having a proper occlusion. Now, if you don't correct it, obviously the bone destruction is the final answer. You keep on, you just say that there is something called as real effect, resiliency like effect. What they normally say, what, certain articles says that the denture seeds itself. After a certain time, the denture, accustoms to the arches. Therefore, the occlusion will come into contact. No, resiliency effect is right, but definitely you should not leave the patient before without looking into premature contact. It will destroy the bone. The bone destruction is ultimate. Moving on with our next question. Complete denture is delivered to the patient, but he comes back after 24 hours due to discrepancy in centric relation. Patients who have a complete denture, there have been issues with his or her centric relations. While recording a jaw relation, we should record in a correct centric relation. When the patient have lost the teeth, obviously the jaw relation is messed up. He brings it forward to bite, and that's the proper rest position should come for a mandible. Now, again, the problem is that there is discrepancy in centric relation. Now, what to do? Rebasing. Rebasing cannot be done for a centric relation issue. Kids, please understand that. Again, grinding of the teeth, definitely not an answer. It's always a remounting is there. Remember, when a centric relation itself is messed up, that is, the relation of the upper and lower jaw is messed up, remounting is there. But should it be done in an articulator? Just remount it in an articulator and repeat the CR? No, definitely not. What you should do is you check the patient's bite. You take a record of the patient bite, remove the dentures with that bite, and then remount it again and correct. So remounting is there in option A and option B, but here they say on option A on an articulator. Option D is where they are talking to take a record. So again, D is the answer. Now, ideal length of a bar to support a prosthesis. Now, I started and early in the first 5 questions, somewhere I talked about overdenture. I'm repeating it again. Overdenture attachments, in that comes of bar attachment. It's also in implants. So the lengths are varied. But remember, again, it's a numerical question. The number should be 10 to 12. But also 22 to 24 is again an option. If for a implant supported bars. This is a implant supported bar, but I'm just showing you the how a bar supported processes happen. Again, moving on with the last set of questions. A patient reports that the denture is initially tight. Okay, so probably the denture is tight when the patient is not talking and stable on wearing but loosens after some. Now, what can be an issue? If there is excessive pressure on the impression, it loosens. If there is increased reading, tiredness would have been an option. If there is basal seat defects, it wouldn't have seated initially only. But the patient is telling that it's tight and stable on wearing, but after some time it loosens, smile gets loosened. Now here the answer is occlusal disturbances. Why occlusal disturbances? The patient won't simply sit after wearing the denture. He won't sit and look around, right? He'll start talking. So when there is, disturbance. Sorry, hello. Yeah. Okay. So when there is occlusal disturbances, there can be issues with the denture being not stable after certain time. Moving on with our last set. Again, if a denture is fabricated at reduced BD, then the position of mandible with respect to maxilla will be. I have added this question because we talked about vertical dimension a lot. Remember this one also. We always talked about increased VD. Now the VD is reduced. VD reduced means the lower mandible is going, towards the maximum. And here the option is forward, backward, superior, no change in position. Children, please see this image. This is the image. You see, this is how a edenturism can affect. It's called a witch-like appearance, okay, or a half moon-like appearance that we say. Here you see on the third image how the mandible have gone forward. This same thing happens when there is loss of bleeding. The mandible goes forward because you don't have, the support. So to get support, the mandible will go forward. Now I have a bonus again case-based question. We have conquered, around 30 questions. So we end with this question, that is, a patient with recent history of denture fabrication reports to the dentist in 5 days with the following complaints: chattering sound, generalized soreness over the wrist, tiredness after wearing denture for 2 to 3 hours, old look of the face. Which of the following denotes increased VD? It is something from all the questions. This is something that comes with whatever we discuss. You see that it's all repeated, right? So there are basic ideas that I have provided to you. Please, apply these same to further questions that you try. So chattering sound, I mentioned that it is there in VD. There is tiredness after wearing two tiredness, I told. Whenever there is tiredness, please check whether there is VD. Old look face is not there because the patient's face is stretched. It won't give you more wrinkles. So old look face can be rolled out. So 1, 2, and 3. The soreness over the ridge is also a problem for VD is the answer. So I just hope that I have been, instrumental in helping you with these questions. And I would like to say that you just conquered the 30 of it. In those 30, you have, the ability to answer more 300 questions. Because with this 30 only, even if this was the questions from several, NEET and AIMS questions, but these all were related. And this you can yourself, connect to each other, like I discussed with guidance, over denture, complete denture, yeah, vertical dimension, how teeth setting affects, what is the selection of teeth, what is a selection for a proper VD. So that's why I wrote you just conquered 30 and now you can ace 300 more. So any doubts? Yeah. Are we done? Okay. Yeah. Sorry, I couldn't check. Yeah. Okay. Thank you so much. So shall we end the session? Thank you. Okay. Bye and good night.